Welcome back to the second day of Interdialogues as we continue to discuss, deliberate, and continue on building joint capacity. So that we started off.
Again, thank you to everyone who's continuing from the first day to the second. And also, welcome to those who are coming today for the first time. I'm sure there's a mix. It's a particular pleasure. Yesterday, we were all in the main campus of Ashoka. Today, we are in the Trivedi School of Biosciences. And bioscience at Ashoka has a very broad definition. We pretty much consider anything related to biology, which is everything in this world, to be part of biosciences. So we are very non-discriminatory in what we consider bioscience, but in the true spirit of interdisciplinarity. And that's what this winter symposium is really about, that the thought of responsible AI in health has to be fundamentally broad-based. It is not really science alone. It is a very generous mix of humanities into it. In fact, I always argue to people that medicine itself is only borderline science. So much of it is humanities. And I think that's why the setting we are in a university, in a science building, but connected to the social sciences, with deep interests in making impact through the Koita Centre for Digital Health, which is one of the centers of the Trivedi School of Biosciences. So Ashoka follows a structure in which we have schools, the university. The university has 7 schools. Schools have departments and centers. And faculty can either be in a department or in centers affiliated to the school, but parallel structures. And the Koita Centre for Digital Health, of course, is again working on digital health in a very broad definition. The way I said bioscience is a broad definition. We look at every aspect of health from social determinants to environmental. And when we think about AI and how the impact will come, we truly believe that modern generative AI will make a massive amount of difference to healthcare. The old law, you always overestimate progress in the near term, but you always underestimate change in the long term. Amara's laws, right? So this is something we expect to see. That there will be changes guaranteed. Whether that change will be desired is not so guaranteed. And that's what I think all the discussions in this RACE symposium is about, to make sure that we set up the appropriate guardrails so that we go to the desired future amongst all possible futures. And like I said yesterday in one of the sessions, I think any discussion on whether we'll be able to restrict AI or people's access to AI is not going to happen. That genie is out of the bottle. No matter what you wish, it's not coming back. In fact, even when India was asked to have a comment on when GPT came out, many people were asking for signatories on whether we should have a moratorium on AI. India never signed, for the very simple reason that it, as a nation, was idiotic to think that we sign, we stop working on AI and we just wait. That was not strategically right. Yet, knowing that we must continue with this genie out, we must make sure that we think about what people will do. We can say everything that people should not use ChatGPT or Gemini for anything to do with healthcare. We can keep saying it. But in absence, if somebody has no access, they will use it. So we have to work in parallel on providing people alternatives to unreliable AI. We must also work on providing them reliable AI. And how that AI can be made reliable, how it can be made usable, what are the guardrails is something we want to hear from all of you. And this discussion is really that, a dialogue. Only a few people will end up maybe sitting on this side, but the dialogue is really between them, the entire room, and we will capture all the discussions and we'll try to give as much feedback as possible to the community. Thank you all so much.
Thank you, Dr. Anurag. Good morning, everyone, and welcome to this first session on AI and mental health. It's my pleasure to have you all here and to be joined by such a distinguished group of clinicians, researchers, implementers, and policy experts. Today's first session brings together academic, clinical, implementation, and policy perspectives to examine what works, what doesn't, and what remains uncertain, and what is needed for the responsible adoption of AI in mental health. So we are joined by a diverse and experienced panel today. It's my pleasure to invite the following speakers. Please join me here as I read out your names. Dr. Smriti Joshi, Chief of Clinical Services and Operations at Wysa. Ms. Punita Mittal, founder of Soulup. Dr. Anant Bhan, mentor and project lead at Sangat. Dr. Nand Kumar, professor and in charge ICMR care at AIIMS New Delhi. Dr. Prabhat Kumar Chand, professor of psychiatry and officer in charge NIMHANS. And Dr. Abhishek Kumar, national professional officer at WHO Country Office. And moderating today's discussion, we have Dr. Rachana Parikh, mental health specialist at PATH. I would like to invite Dr. Rachana to give her opening remarks.
Good morning, everyone, and a very warm welcome today for this session on AI and mental health, evidence, equity, and paths to scale. Friends, AI is increasingly being embedded in our lives. It has also been looked at as a solution to address some of the most critical problems with mental health care systems in our country. So it's presented as a solution to look at fragmented healthcare for mental health services, looking at critical gaps and shortages of specialists, ease of access. We have among the highest treatment gaps in the country as far as mental health conditions is concerned. In addition to addressing these problems, AI is also looked at as a potential solution to advance personalized care, advanced access to care that is closer to people at their fingertips, literally, and also in a setting where we are looking at stigma and prevalent negative social attitudes towards mental health conditions. So the applications of AI as we understand today for mental health are really varied, as you'll hear from the panelists. It actually spans across almost all of these areas, right from screening and identification to self-management, to actually supporting clinicians in making decisions and providing care, in terms of using tools to support delivery. But the pace at which it is growing, sometimes it feels like it's threatening the pace of us to keep along with it in terms of understanding how it potentially impacts us as individuals, societies, communities, as a country, and as well as a public health system. So today's session, we are here joined by panel members who bring in diverse set of experiences. And through their career journey as well as their learnings, we would like to explore some of the questions around this to test ourselves, to understand what is the actual situation around AI and what it holds as a promise, as well as what is it that we need to know more. As you reflect to our today's session, I'd like you to ask yourself a question. Would you be using AI for mental health? If and whether. And probably a more important question to ask is whether you would recommend someone use AI for their own mental health conditions. And probably the most important questions that we have today in front of us is, what do you want to know? What should you really know? What should we know as a part of the system to make that recommendation and provide the most informed choice to an individual who uses AI for mental health? So with that, I'd like to start this session. Today's session is in 3 parts. We'll first hear from every panel member, what we are calling them as lightning talks, talking about their own work, and also reflecting on the larger application of AI in mental health, bringing some critical assumptions, opportunities, as well as concerns in front of us. Following that, we will deep dive as thematic group discussions, round discussions on evidence, research, the existing status of evidence and research. How does that really work out for realities with respect to clinical care and ethical realities around a use of AI in mental health? And finally, we will explore what it means in terms of forming some principles and structure around governance, around regulations, and implementing AI in mental health at scale for a country like ours, with deep intersections of equity as well as diversity and vulnerabilities as well. After that, we'll have time, and we must keep time for audience interactions. And so while you listen to this conversation today, please ask yourself this question. What would you need to know to make a recommendation on use of AI for mental health for yourself and for someone in your community or family? It could probably be a young person who's 18 years old, and it would also be an older person around 50 who's struggling with cognitive decline. So there, over to you. Let me please invite our first panel member, Dr. Prabhat, to present his lightning talk. Dr. Prabhat is Professor of Psychiatry and Officer in charge of Center for Addiction Medicines in NIMHANS. He comes with deep expertise in public mental health, addiction care, and the application of data and AI within complex health systems. We look forward to your perspective, sir.
Okay, so good morning to all of you. I think doing this session in the Sonepat ka thand mein mushkil hai because Bangalore is never cold. I mean, actually, this is where last time in US, pata nahi 5 se pehle, even Trump came, didn't allow us to go. So, but then thank you very much. Thank you very much. So, I think, yeah. So, I work as an addiction psychiatrist. So, I basically see many young people like all of you here and old people also who has addictive problem. But basically, I'm a psychiatrist. And many of the presentation is from my colleague 𝐏𝐚𝐧𝐞𝐥 who actually is a doctor come engineer. And he does many stuff and I have actually borrowed from him. Although I'm the co-PI, but I have little less knowledge. So, okay, now this is a diagram, it can hide now, is it not? Again, it's I have some slides from AI only. Don't worry about that. You don't know that I have made many slides. Don't worry about that. It's all AI. I have I tell somebody, my students, 5 AI runs in my system parallelly because I can do your MD and PhD thesis correction with seeing patients. So somebody help me. So you can't hide now because there's nowhere to hide. I mean, no place to hide. Everybody know. I mean, you put Google name, one of the name in Claude or ChatGPT to get the guys everything in their life. What is that? So obviously, and it's more for India because if you look at last survey, it's very surprising that diagnosable psychiatric illness, we're not telling about chinta, tension, exam में fail हो गए, forget about those things. Diagnosable depression, जिसको diagnose कर सकते हो, you can diagnose. 80% of people are not getting care. 80%. Can you believe a country like India and out of 100 people don't get care? Then things are not good, I think. I mean, I'm not talking about the symptoms of a diagnosis. So you have to have some mechanism, at least do some screening, do some little bit, but you can't hide, you have to do it. Now, these are the few work that we have done very recently, as I mentioned. So one of the problem we always face in our OPD, as I told, I see many addiction patients, and many of the patients need a lot of psychological intervention or discussion about change the motivation to not living, to think about living or quitting completely from gambling, gaming, from alcohol, tobacco, cannabis, everything. But half energy goes in entering data. History taking, kab se liya, when you started, how it went, who is the problem. Then how much time we have in a busy OPD, 200% come to a public sector OPD. How much time you will have to give? So we realize that can you extract those data, the notes of the end. Remember, the challenging in notes is different because at least in NIMHANS, Telugu, Tamil, Hindi, Kannada, Malayalam. And sometimes I know only one or two languages. I'm from Orissa, learned Malayalam, did MD and PGI. So I also know limited language. So we have another barrier comes language barrier. So then we did a study where extracted the data from the EHR. We have a small EHR, European Health Record, and tried to look at did it help. So you can see here, human evaluators preferred AI notes, and fortunately it was an open source AI. It's not sort of a paid one. And you look at some findings. Only it took $500 to develop it. Again, it's not non-scalable with small model. You can see, and most important, you see, there's 16 minutes to 2.4 seconds. So look at notes, summarize. A summarizer can decrease the notes timing. So that 14 minutes goes to the person who is sitting in front of me because, there are the queue, people are waiting outside, they want to come, they come early morning. So at least you can give a little more time, which your skill that you have. That is one finding. Now, misinterpreted, man bhari rehta hai. Those who are from this belt, man bhari rehta hai is different from here, from Urdu speaking person in Bangalore telling man bhari rehta hai. So that again, one layer of problem comes in that findings. So I'll just look at the challenges that you see here. Today morning I was discussing with Dr. Parikh that LLM are optimized for engagement, not for clinical outcome. They will give a social desirable response. They love to give a response which you are happy in that. And this example I've given here. This is a gentleman who has an antipsychotic for 5 and gained some weight. He tells you medical decisions are best taken by specialist, speak to doctor. Whereas validation happening in other statement. I can understand that you are facing a problem.
So then you don't know what the person is going to do next. He doesn't immediately prompt you that you should go and discuss somebody. He just validate your statement. Once you validate the statement, obviously you might feel little solace, happy, and then you delay your practice to go to the person, but then it obviously, or you might think, can I decrease my half latency? And your symptom exacerbates completely, start hallucinating. So those are big. So what AI tells you is what you want to hear. Instead of it's good for general conditions, but when you're talking of somebody's illness and how person recovers, it may not be something desirable. And I think Sam spoke about few days back some term called parasocial attachment, honesty versus helpfulness, and psychophancy need to be engagement and increasing profit. This is another term. Psychophancy is they want more and more people to come to engagement to the platform than actually, and obviously financial part of the whole involved in those things. So last paper we will close up this one. So last one we actually the problem in psychiatry, it's a very cultural relevant. When I was doing MD in PGI, Chandigarh here only, I remember Himachali and boy came, and boy came late night, early morning. He has actually cut his penis. And that time, 20 years back, I asked him why it happened. He landed in plastic surgery. After recovery, he told that time Russia and America has a lot of fighting going on, and HIV was in peak. I'm telling 20 years back. He told somebody told him, Russian president told him that if you don't follow certain rules, he'll give HIV injection. And obviously HIV used to be a very dreaded condition at that point of time, those 20 years, you're much younger now. So then he told, look, let me die like this only. Why should I get HIV? So if you look at cultural events, getting HIV is not infection, stigma. Families get sort of completely stigma in the area. So psychiatry on branch of medicine, culture plays such a significant role. Now somebody tells you I have a telepathy, you can still think, okay, some chat GPT is working. But 10 years back, somebody put my chip in the mind. You think there's some problem with this guy, he looks schizophrenic. But now you have to think 10 times. Many things happens which are implausible, has been to some extent not true. Okay, so my thoughts at the end. So present direction, at least I'm talking about psychiatric illness. I'm not talking about the general mental health condition. That's a completely broader. If you look at illness part, at this point of time, profit is actually dictating. Science comes second part. At least I'm telling illness part. But as Sir Anurag did mention at the beginning, public will going to use it because we don't have option for them. I mean, you don't think of a time when Amazon was not there. You have no option to go to the shop and you don't know how to bargain him because you don't know the cost. So we have to, but that's a problem that we need to understand the changing field for all of us, and is our duty to how do you sort of this dialogue's vision is it how do you make it at least some checks and balances so that things become better. Thank you very much.
Thank you, Dr. Prabhat. Next, I'd like to invite Dr. Smriti. Dr. Smriti is Chief of Clinical Services and Operations at Wysa. She leads the clinical design and real-world deployment of this platform and brings to us today practical insights on how AI tools are built, governed, and integrated, especially from a clinician's perspective. Over to you.
I'm very honored to be here. There are a lot of people here who are in the panel who I've been in awe of, who have inspired me. Dr. Chand, Dr. Anand Bhan, Dr. Nand, Kumar. I haven't met all of them in person. So first of all, thanks for this opportunity where I'm meeting a lot of people I have learned from vicariously and from a distance as well. AI in mental health it's not a debating point anymore, like Dr. Anurag initially said. It's the genie's out of the bottle already, right? It's already shaping access and expectations of care, often faster than ethics and regulations can catch up. And I was asked to name one mental health constraint. This is it. That the speed at which the AI is evolving, it is very hard for the guardrails that we hope should be present versus what is actually present, versus with the speed that the AI the technology is developing really fast, the regulations, the regulatory guidelines, it's hard to keep up, right? Behind every health innovation, I feel, is a human story. So is behind AI for mental health. There's a person in quiet distress, a clinician navigating complexity, and these are the people we keep in mind when we are building our AIs, different use cases in mental health. There's a system which is striving to do better with the tools it has. And as we expand access through AI apps and hybrid models, we must keep asking ourselves one deceptively simple question. Are we building systems that are scalable? and efficient, but safe, equitable, and profoundly human. Are we also keeping that in our mind when we are building for them? I arrived in this space 10 years ago, very much pre-GPT, seems like pretty prehistoric dinosaur era work that probably I have began with. My first task was to write scripts. Very first principles as a clinician. We didn't have, here's a GPT for that. You just plug in, and you have some things which are ready made, which will be spinned out very quickly for this use case. So I began at a time where I was asked to write scripts. That was my first assignment. It was not an easy one because sitting here in my house in Delhi, NCR, someplace, I have to ask a question. How are you feeling today? And because we deployed real world, we didn't begin in a lab. It could be anyone from any part of the world answering that question. And what I wrote in that script as a clinician should have at least made them feel better or good or not cause any harm. And that's one of the basic principles we follow even in medical ethics, isn't it? So I think something that helped me stay grounded and which has helped us remain grounded in the basic pillars that we have to remember, it has to be clinically safe, is to remember that even though there were no regulations back then or there were no guardrails back then and we were learning by experience, we could always begin from what exists for us, which is, for example, the basic principles of medical ethics, non-maleficence, beneficence. All of those things are principles that guided our work. As a clinician, I was trained to notice nuance, silence, hesitation, the tremor in a voice. So when I first encountered conversations about chatbots, when I was first interviewed for this job, I asked Joan Ramakant, really, who are our founders? Is this really going to work? And you can just keep my work very contractual 3 months because I think I'm going to leave because I'm a clinician. Past 10 years before I entered the space, I was a clinician sitting in a room with my patients. Can technology really hold what human carried? I worried about oversimplification. I worried about safety. I worried about harm delivered at scale. But I think in the past 10 years here at Wysa, I've also seen something else as we have evolved in the past 10 years. We've seen about 500 people who've written to us saying Wysa saved their lives. I've seen stories of people who found support at moments they otherwise would have none. Stories of clinicians who felt extended and not replaced. So 100% AI was doing something which our current systems were not equipped to do at scale. So as a digital mental health, we must begin from the premise technology cannot replace the human core of care, but it can extend it, widen its reach, and hold space when systems cannot. Another set of principles that have guided the work that we have done here is principles which are again listed across WHO, World Psychiatry Association. Basic guidelines that exist globally are safety before scale, transparency and trust, privacy as dignity, equity by design, and human oversight. These are non-negotiables. And when I was going through and preparing ourselves for the first launch, these sounded like big words. How would we translate them into action, right? How would it translate into action when Wysa would be having those conversations or when people would be downloading Wysa? How would it meet the expectations? So how do we translate these principles into everyday practice? I think I found my answers in trauma-informed design principles, which is safety, trust, choice, collaboration, and empowerment. In digital systems, it would look like predictable grounding tone, transparency about AI limits. So when you speak to the bot should be able to say, I'm a bot. It should not pretend to be a human, which is something we really struggle with in the chat GPT era, where there are people who have you heard of Replica? How many of you have heard of Replica? Yeah. So Replica has been there for a very long time. It was not built for mental health, but we all know ChatGPT is not built for mental health. But people go and have these conversations with these bots available. They bring the semblance of being a human. They claim to be human-like, unlike the claim should really be we are humane and not human-like. Because when you say human-like, that is misleading. That causes a lot of um, uh, it clouds the user's mind. It can make them feel they're talking to a real human. It can change their expectations of support from there, and it can lead to also many harms. Um, And one example of something really important is also to keep in mind, who are we designing for? What is the purpose? What is the evidence that is already there? So it's also important to remember that even though, for example, companies like ours, when we began, we launched Real World, we didn't begin with a direct launch that was accessible to everyone. It was beta. It was they were a user cohort that was already present. Every tool, every bot that was released was tested by the board, the advisory clinicians who were there on the board, by the non-clinicians in the team, by the cohort who we were trying to reach, which were people not probably who were not aware they had a diagnosis, but somewhere they had subclinical systems. So we had to reach out to universities, we had to reach out to corporate houses to see if there were people willing to volunteer and test our bots. So even though we say we are real world deployment, we first began in-house in terms of testing these tools, these conversations for their safety, their clinical efficacy. And we have to understand, what is the purpose? Am I designing for screenings? Am I designing for triage? Am I designing for diagnosis? Am I designing for treatment? And all of this needs to be reflected in very transparently at the time when somebody is starting to use your bot, in your FAQs, in your terms and conditions. So people are very well aware that if I'm going to use this, I'm not going to be diagnosed. I'm only going to receive X kind of support. I'm only going to receive X kind of escalations, and I'm going to be handed over to a clinician, or not handed over to a clinician, but to just escalated to certain helplines. What we saw consistently, that when people engage with short, structured, skills-based support, journaling, emotional naming, grounding, reflection, they reported feeling more self-efficacious. They were able to build richer emotional vocabulary. They were able to feel more comfortable, and the transparency helped build trust. And I think we can't compromise on the trust, because once trust is there, people will be using it in the way it is designed to be used and not expecting more out of it, which is really important when we talk about responsible AI. And I think this is also where the human in the loop becomes essential. In mental health, judgment cannot ever be fully automated, and we have to remember it with all our will. Clinicians need to be involved not only at moments of escalation, but throughout design, testing, supervision, and review. And people with lived experiences need to shape what feels respectable, usable, and safe. And without these, even the most sophisticated systems drift away from care. I'll just like to end with one example. When we built initially, we built for people. We built thinking everybody had smartphones in their pocket. Everybody do have smartphones in their pocket, but there are people in low resource settings. I would not say low and middle income countries, but I would say low resource settings, because they exist across the globe, even in high income countries, right? There are phones which are shared by entire families, and when we wanted to deploy specifically in India for our Indian communities, bringing all the learnings that we had from a global use case, we realized bot to nahi chalega boss, because किसी के पास तो phone भी नहीं है, and it's being shared, just one phone, one device, which is in families. So the privacy, the safety, everything goes for a toss. People can't have those detailed kind of conversations that they're having with our usual bot that's available on the Play Store. So what we went and did is that we did co-design work with different cohorts, whether they were rural women farmers in Rajasthan or young adolescent girls in Maharashtra, from tribal communities. And we realized what would really work for them is a blended model, which we now call the digital model, where there are workbooks with QR codes, and the QR codes takes them to skills and techniques that the bot teaches. And there is humor in the loop, where the community psychologists are going to schools, to organizations, where we can find our user cohorts, helping them understand the usage of the bot, and also supplementing it with workbooks which have the same kind of education and awareness and sensitivity that we would want them to develop from the usage of the bot. So we had to evolve with the times, with the communities that we are serving. So no one size fits all is again something that we really need to remember. I think I'll pause there. Thank you.
Thank you, Dr. Smriti. Now, please let us welcome Ms. Punita. Please share with us your work with Soulup and help to see how this works out for very vulnerable group of population, young people, as you provide care.
Hi everyone, my name is Punita and I am the founder of Soulup. We work with peer support for mental health. So before I go into how we are planning to use or working to use AI within Soulup, I'll give you a quick background about myself and what I've done before this. So I've been working at the juncture of data and health for 15 years now. Before starting Soulup is something that we've been building for the last 3 years now at Max. I was heading AI at Healthify, and I don't know if you've heard of Healthify Me, but so what I think a lot of my learnings came from there, and realized that mental health is a very different ball game. So a lot of unlearning has happened, which I will go into. But what really I've taken from my experience was because, again, at Healthify, as somebody pointed out, we were building for the real world. We weren't in a lab. We had to put something out there. That's how all startups work, because you're kind of juggling what you want to do, what needs to be done versus what you think is right. So what we built, this is again pre-generative AI 2018. We shipped out something within the year, which why it helped us was, one key learning that I took from there was it's very helpful to build AI systems which are very only inch wide. So you're looking at narrowed scope. They might be mile deep, but you're looking at very specific scope, which is what we were dealing with. We ended up building the world's first virtual nutritionist and fitness trainer. And what the other thing that we ended up doing was embedding in the system very straightforward rules for human handoff and real-time feedback. Within the year, we had this system was called RIA, and it ended up serving 3 million users, and now is the center and face of what Healthify offers to its users. So jumping to what we're building at Soulup now, before I go into how we plan to use AI, how we are building AI within Soulup, I will talk a little bit about what we are building at Soulup to give you context. So the deep belief with which we are building Soulup is that human connect is essential for mental health. A lot of mental health is far worsened when people feel like they're solving in isolation, where they feel lonely. It's important to be able to solve with other people in the same boat. And with that philosophy in mind, we are trying to build an ecosystem of peer-led products. What we started with is something very simple. We started with support groups, therapist-led support groups. We are currently in India's largest collection of support groups across topics. The other thing we are building is one-on-one peer support. So imagine like a micro LinkedIn where you can find other people who've solved the same thing that you are solving, discover them and speak to them. So that's the two things that we started with. But keeping this in view, how is it that we want to leverage the power of AI and build something which is far more effective or efficient? So there's a lot of, let me come to the first thing that we're trying to build. Now we are, like I said, we are only 3 years into building this. So we're kind of laying the brickwork. So this is the other side of, when you're actually far younger, how do you lay the brickwork for building something responsibly? There's a lot of research, a lot of questions. A lot of people say, okay, whatever you build, it has to be responsibly built. It has to be outcome focused. It has to be quality. But what are the problems? A lot of people don't know where to look. It's very hard to discover what is the right thing for you. A lot of right things are being built, right? But it's very hard to discover. And everybody has a very different trajectory in mental health. You can't say that I and you have the same challenge, so let's follow the same linear path. It doesn't work that way. Everybody has very different needs, very different states of readiness. So the larger narrative, one of the narratives here in mental health is that people need care coordinators. Somebody to tell you, look, this is where you are. This is what you're ready for. This is what you can pay. Let's start here, right? So you need care coordinators. What we are trying to figure out is, can AI be one of the care coordinators? What do we need to tell AI? We need to tell AI, okay, what kind of profiles are more ready for solution A versus solution B? What kind of profiles feel threatened by solution C, right? What happens when you put a certain person in this kind of situation? Do they continue or do they drop off? So all of that data is being collected to see what kind of care coordinators can AI actually become. Can you recommend solutions, etc.? The other thing that we are trying to do is, again, going back to our belief that a lot of mental health happens within community. You don't want to do this alone, right? All the AI that we've been speaking about is focused on one-on-one conversations. Me going to a bot, talking one-on-one. It could be helpful, but it still leaves me alone, right? Now, can we actually include AI in a community setup, Is that possible? We run a lot of support groups. Can we make support groups more efficient by involving AI? There's only so much that a therapist can do, right? If you want to do this at scale, can we involve AI? How do we do this? So we are trying to collect data on what is validating in a community, in a group setup. What language is validating? Where is the scope for silence? Where is the scope for storytelling? When do people start going into, this happened and then that happened? People start narrating incidents, and what is the rest? How do people react to it? Can AI then start participating in support groups as a co-facilitator? Can it prompt better? Can it provide summaries? Can it help pace the group? All of this. So again, saying, can we move AI from one-on-one to slide facilitation in a group? And the third is, again, when we talk to AI, we ask for solutions, right? We say, okay, I want to solve this. But that's not how humans talk. A lot of human conversation is broken, fragmented, repetitive, also contradictory. If I'm telling you about my toxic mother-in-law, good chance I'll contradict myself 10 times in that conversation, right? So we say, okay, can we actually help AI capture all of these expressions and then help support when humans talk to each other? Make that conversation more impactful, more helpful. All of these things, what we are seeing again and again is that what AI is really doing is strengthening human connect, not replacing it, strengthening it, because at least for the shorter time being, human connect is not going anywhere. It will remain central to building mental health. So that's like what we think will eventually happen. That's what you're building towards. And it brings me back to the key challenge. That a lot of times when people talk to AI, can AI actually discern that is this person coming to me with a problem, a specific problem, or is the need slightly deeper, where they are just feeling alone and they need to talk to somebody, and the only way they know how to talk to a chatbot is by stating a problem, right? And then falling into that circle, into that vicious cycle. So is there a way that AI can differentiate when that handoff needs to happen, where they say, okay, looks like this person doesn't need solutions. It just needs to connect to another human being, right? Where does it step back? And AI learn to step back and say, I've done my job here. Now is the time that you need to maybe access a social resource or a real resource. So that's the challenge, at least how we look at Soulup, and that's what we're trying to build. Thanks.
Thank you, Punita, for sharing those insights. And if you were to answer one question, saying what's the most critical insight you want to share as either an assumption, concern, or even an opportunity for AI in mental health, what would your top pick would be?
I think the top one would be understanding. I think Dr. mentioned it, is understanding expression, because it's very, very broken. At least that's what we've uncovered. Because again, we're talking about human connect. None of this is possible unless until AI understands different ways of expressing the same thing. I think Dr. Prabhat also went there. So that's something that was key.
Wonderful. That's talking about humans should be in the loop, but exactly how and when. Thank you so much, Punita, for sharing your experience about Soulup. And let me please now invite Dr. Nand Kumar. Dr. Nand Kumar is a professor and in charge of ICMR care in neuromodulation for mental health in Department of Psychiatry at AIIMS in Delhi. He represents a clinical academic perspective, and coming from AIIMS, so we are really hopeful to listen to you in terms of patient safety and your experience with.
Am I audible?
Yes, over to you.
Good morning. Thank you for inviting me. Really glad to be here. A beautiful campus. So, mental health and AI. For AI, you need data. And the topic is mental health and AI. If you go with the data for the research, what we have done, if you just search one simple search engine, PubMed, the AI in mental health, the articles are 12,000 plus. 7,000 plus. Mental health. And AI in mental illness, the articles are 12,000 plus. So it is very interesting to know and learn and to work on mental health, because there is more data on mental illness and mental health. It's very interesting, no? Tricky. Now, look at the definition of mental health. What WHO says, mental health is what? A state of well-being, where we are able to cope with normal stress of the life. We're able to learn, able to work, and able to contribute in the community. So, if we follow this definition, it's difficult to say who is mentally healthy because it's so subjective. It is very subjective, in fact. Now, coming back to the data again, no, if I quote the recent study published in BMC 2025, last year only, it is a systematic review, and they reviewed 2,000 plus articles, and they focused on only 15 articles, very comprehensive articles. And there is a sufficient data that AI is useful for mental health intervention. And most important, what they have focused in, that AI is needed for mental health early detection, mental illness early detection and intervention. So early detection and intervention is most common focus of all the research that what has been done in the last 10 years. And this all data has surged, that all data has been collected in last 5 years, because 90% of the research had been done in last 5 years. So we are moving very fast in terms of the AI. Now, for psychiatry, I think mental illness and mental health both, the most troublesome thing is the treatment gap, what Dr. Prabhat had mentioned. And treatment gap is so huge, it is up to 80 to 90%. That simply means the 80 to 90% or 75 to 80%, at least, people are not having treatment if they have any mental health problem. Means mental health issues to illness, all. And this treatment gap, we frequently say, is because of the lack of resources, lack of psychologists, lack of psychiatrists. But not that true. What we feel, I know up to some extent is true also, the treatment gap is mainly because of the awareness. A lot of people who suffer from mental health problem, including psychiatrists, they are not aware that they are having mental illness. And one of the most painful complications of mental illness is suicide. And suicide is not very rare, uncommon in psychiatrists. Recently, one of the psychiatrists died just last year only, few months back. And he worked on neuromodulation, and he contributed in faster neuromodulation, what we call TMS acceleration, to treat depression faster, from Stanford. So I think the most critical part is the awareness. The people who are having the problem, if it is a problem as per ICD and DSM-5, they are not aware that this is a problem, because they attribute to others. कि इसके चलते हुआ, घर वाले के चलते हो गया, ब्रेकअप हो गया, गर्लफ्रेंड ने छोड़ दिया, multiple things in fact, social issues है, political issues है, so many. So we try to do something on that, how to detect early and how to do some early intervention. And we developed some sort of digital screening instrument to screen the mental health problem or mental illness. And this is based on DSM-5. And this is what we call a never alone. So if we are able to detect and diagnose problem digitally, so a lot of problem can be solved. Why I'm saying this? Because at times the access is there. The access of the professionals are there. But people don't go for the treatment because still they are not aware that what they have is depression or schizophrenia or bipolar or OCD. So what we have done the last 1 year, we have developed a chatbot, and that's basically to screen the mental health problem, mental illness, including de-addiction also and personality issue also. It takes about 5 to 7 minutes for the screening. It's a basically DSM based all criteria are incorporated, and it can screen any mental health condition as per the DSM-5. So this is a kind of mini workup. Like in the medical setup, when we work, we need some sort of workup, some sort of assessment. It's a kind of a digital assessment that we are doing, and what we are observing that approximately the accuracy rate to diagnose the condition on the chatbot basis is approximately 90%, 85 to 90%. And we are using it in few setup, and we are trying to expand it more. And the cost is minimal, in fact. Minimal means actually minimal. I will not disclose that. So we are trying to focus the institutions. Why? Because the suicide rate is very high in the institution. In India, the suicide, unfortunately, in the youth is almost 40%. So we're trying to use this system, this screening system in the universities and campuses, other campuses, ranging from AIIMS Delhi to AIIMS Bhubaneswar to some private university also, so that we can focus on early detection and treatment through the AI. Thank you so much.
Thank you, Dr. Kumar, for sharing your insights. If you were to highlight your topic, sorry, my job is to ask a question before audience gets the pick. If you were to name your top pick of probably an assumption or an opportunity around AI in mental health, what would it be?
I think the topic you have mentioned, the responsible AI. I think for mental health it is most important, the responsible AI, because in mental health, any screening, diagnosis, intervention, the accountability, ethics, and transparency is most important, because it's very fluid area. It's very difficult to diagnose. Like, you may diagnose me depression based on my information. I may not be depressed. So the responsible AI is most important in mental health than in other health areas. This is what I feel.
Thank you for indulging me. Next, please let me invite Dr. Anand Ban. Dr. Ban is mentor, principal investigator, and project lead at Sangat India. Many of you may know about Sangat being a public mental health research institution in our country. Dr. Ban is a leading voice also in ethics, implementation, research, and health systems in mental health. He brings today his experience and his perspectives on evidence, accountability, and governance as well for AI in mental health. Over to you, Anand.
Okay. Good morning, everyone. Hi, pleasure to be here. Some known faces, some unknown faces. I was trying to be here for yesterday, but couldn't connect. But I heard that there were some really engaging conversations, and I'm sure today will be also quite productive. So as Rachana was mentioning, I am representing Sangat. Sangat is a public health research NGO. We are now in our 30th year. And one of our focus areas historically has been working on mental health. We started from a small child development clinic in Goa, but now work in almost 13 states. And one of the things that we focus on is something which Dr. Nand Kumar and Dr. Prabhat were highlighting, which is the treatment gap, though I prefer to use the care gap analogy, because I think treatment is one aspect of the larger care paradigm, which is very relevant in mental health. But the fact that there are many people, especially in rural communities, who do not have access to mental health care, but also figuring out mechanisms to make that care available in a way that is sustainable. And especially so by working with health systems, because I think one of the equity gaps in mental health is the fact that a lot of mental health care is largely available in the private sector and not so much in the public sector. So how do you actually integrate with health systems is a major issue. And how do you do it also in a way that it's representative of the kind of diversity we have as a country in a cost-effective, scalable manner. So one of the approaches we have piloted historically at Sangat is an approach called task sharing, where the idea is to train community resources. So these are either community health workers, members of the community, to provide first-level mental health care. The idea is that, again, it will take a long time for us to have enough psychiatrists and psychologists, but can you train community health officers, ASHAs? Can you train medical officers? Can you train nurses in rural facilities to be able to do first-level screening, deliver first-level care, and then link or refer when needed, right? So that's the idea behind task sharing. At the heart of it is capacity building and training. So you train them in evidence-based mental health care provision, but also an important component is building in a supportive supervision model, because as you know, from any training model, you cannot just train and let people directly interact with, let's say, patients, right? That's why when you train medical doctors, you have an internship model where there is a supportive supervision, there is some level of oversight which is available. But how do you translate that when you're doing mental health, especially with in frontier settings? So the idea here is to build in those mechanisms as a core component for safety and also to ensure that there is fidelity of care provision. So, of course, when you're trying to create lay counselors who are also from the communities, right, because they're embedded within those communities, hopefully understand cultural context better, and then, of course, strong referral pathways. So some of our work, especially in central India, has been primarily with ASHA workers, and we've tried to work with them on adult depression and care provision, but also now increasingly so on perinatal depression. So just as a reminder, we were talking about data points. 80 to 90% treatment or care gap for conditions such as depression. 1 in 5 pregnant women or lactating women is likely to be dealing with a mental health issue, often depression. India has historically, for decades now, invested in maternal and child health as a priority focus area. But on a large scale, no pregnant woman gets screened for depression, right? And this has very poor outcomes, especially so for the woman herself, if she were to have a mental health challenge, but also for her future child potentially, right? So we are already losing out on the chance that we could have intervened early and provided care. So those are the kind of things where ASHAs could come in and provide a lot of inputs. Now, one of the challenges when we work in task sharing is then how do you build in this supportive supervision model, right? Because it is quite resource intensive. For example, if you have multiple sessions being delivered by thousands of ASHAs in the community, because that's the health system scale that we are talking about, then how do you ensure that for each ASHA there is a mechanism to provide oversight? And often, of course, you can record it, but there are challenges with doing that as well. But let's say even if we record it, how many of those sessions can be heard by an expert, right? And then graded and then feedback provided so that quality of care can be maintained. So that's going to be an ongoing challenge, because ensuring that you are able to do that at scale is a major issue. So one of the things we've been thinking about is, can AI help, right? And that's where some of this pilot work that we've been doing called Bridge AI comes in, where the idea is to look at Indian data sets of, these are transcriptions of depression care sessions, which have been translated. And then we are trying to pick up and see if a human supervisor were to do supportive supervision, and if we were to then train AI using the Indian data, would that be useful to be able to flag where there are inconsistencies, where there might be care gaps, which then can be escalated to a human expert, right? So that the routine supervision could be done by the AI, but then that where the flags are there, then those are then directed to an expert so that you are able to better manage the resources. So that's at the heart of what we are doing with Bridge AI. So the idea here is around 4,000 behavioral activation sessions that we have in one of our largest randomized control trials, which is just finished with 1,500 patients in Bhopal, and see how that can help. But also doing this by co-development and human-centered design. And so the idea has been actually to work with a lived experience advisory panel. So these are individuals with lived experience of depression, and they are part of the design right from the inception of this project. And in terms of how we develop this pathway, incorporates all of their inputs. And that, I think, is an extremely important point, because a lot of time the design element is something that we think from a technical perspective, maybe from an expert perspective, but not from a lived experience perspective. And unless we design for the user in mind, I think those deficiencies can become major gaps later. So we've been trying to do that differently. And of course, the user here is also the person who is providing the care, right? So the counselor, who is a lay counselor, and then getting their inputs as well. So hopefully we'll see if this helps, because there is going to be an evaluation at some point of time. But this is the kind of integration of AI pathways into the kind of work that we are doing in community mental health that we are quite excited about. Of course, we've known about some of the challenges of working in the digital mental health space, and AI is just one of the continuations of sort of the interactions of mental health and technology, which has been happening issues around technical clinical standards, validation for online platforms, apps, or any other kinds of platforms, issues around privacy, confidentiality, because stigma remains one of the major reasons why people do not access mental health care, why people are not comfortable with accessing even screening. And Dr. Nand Kumar was speaking about the fact that this is true of the medical profession as well. In fact, suicide rates among physicians are 2.5 times higher than the routine general population. And many of you would have heard of instances of medical students or doctors dying by suicide as well, right? Data sharing, because this could impact how people feel that they are perceived by the external world. So keeping that secure, whether this data, who has access to it, how do you work with private players, commercial players? Would data become a commodity, which already it is, right? So that's how, as you know, Facebook, Meta, Instagram, any of these other platforms basically are multi-billion-dollar corporations because of the data that you and I share with them. But of course, issues around bias, who has access to it? Is it equitably available? And is it sustainable, right? Which is something that at the downstream end, those of us who work in communities always worry about, because I think there is a lot of fascination with technology and platforms, but a lot of that plays out at the pilot level, at the project level. But what stays on is something which is a much more minuscule subset of what gets tried out. And that's something we need to think about. Of course, we also know the reality in today's world that quality of care is a major issue, right? That everyone claims to be a therapist. The Instagram reel version of a therapist is there. Everyone gives you the tips of how you can improve your mental health. The real question is how much of that is evidence-based, right? And this is not to say that there is not a role for social media in mental health. There is a strong role. But at the heart of it is ensuring that it is based in evidence, right? Because one issue is that it could be useless. The other more worrying aspect to it is that it could be risky. It would actually put those who are vulnerable in a vulnerable state further at risk of something which could be a poor outcome, right? So that's what we need to think about. And then, of course, then you apply AI on top of that or layer that on, then that could additionally amplify the risk involved. And this is where I think now there is new terminology in mental health, including chatbot psychosis, AI psychosis, where some of the perceptions we have about mental health and the causative factors or some of the trigger factors can actually get reinforced by AI, because it sort of is designed in a way that it reinforces some of your own beliefs, right? And so now we are increasingly seeing this being reported. Mental health specialists speaking about people coming to them in a much more advanced stage of mental health pathology, which has been somehow triggered further by the use of AI and chatbots. So that's a safety concern. That having been said, I don't want to leave you with a thought that it's all gloomy and negative. I feel that there is a lot of scope for AI. Our own work, we have been trying to leverage it, but it has to be done in a way that we are careful about it, right? So, Rachana, to preempt your question, I think we've all talked about responsible AI. I'd like to maybe change that around a little bit and say that what I would think about is responsibility in AI, right? How we engage with AI, how do we work with AI, and how do we ensure that there is adequate, sustainable oversight mechanisms in a way that we are able to use it, but with responsibility. I'll stop here. Thank you.
Thank you, Anand. Thank you for sharing those insights. And now I'd like to invite our last panel for today, panel member, Dr. Abhishek Kanwar. He is a National Professional Officer from WHO Country Office for India. Dr. Abhishek brings insight from global normative as well as country-level policy. And over to you to share your thoughts on how all this conversation fits into the larger scheme of things.
Thank you, and good morning, and thank you for inviting me here. And actually, I'm not a mental health expert, but recently filling the gap for the mental health in WHO country office. The key area is for the NCDs, non-communicable diseases, particularly for cardiovascular disease, cancers, and diabetes, and other NCDs. So, but it's a very interesting to hear from all of the experts, and it's really learning for me. It's not AI learning for me also. So, but I will give you some context in terms of the WHO, or in terms of what the Ministry of Health and in the country context also. So recently the United Nations General Assembly has passed a resolution for NCDs and the mental health. And now the resolution has been adopted in December, could not adopted in the September because of some administrative reasons, but now adopted. So if you come to the data for the target for the mental health, it says to 150 million more people has to be put on the mental health care by 2030. So this is a big target globally. India needs to do lot to more in terms of the numbers. Second is also tells about leveraging the technologies and particularly the artificial intelligence, AI. But it has to be leveraged in terms of the country context, in terms of the affordability, in terms of the sustainability and evidence based. So what we are talking about responsible AI or what we are talking about the caregiving AI, so it has to be in terms of the evidence based. So I think if I give my example from the NCDs, so since I had taken over for NCDs in 2018, 2019 WHO, and we started working for hypertension, and lot of things have been mentioned by the experts also here. So we built on the 5 essential components, and you can just see the connections between the mental health and the NCDs. So what were the 5 essential components? One was the standard treatment protocol and the care. So that we are discussing here, there has to be some standard treatment because we are talking about the communities and the primary health care also. We should not forget the primary health care here. Secondly, about the task sharing, capacity building, patient-centered care, and more importantly, the information system. So when in 2019 there was the national level meeting on the technologies digital information system for NCDs. One of the state mentioned that there are 72 apps for NCDs they are using. So how many AIs? So we need to see the responsible. I like the word responsible AI or the care giving AI because there has to be some limited, some regulated AI which WHO also mentions in the United Nations General Assembly past resolution, and which is very clearly articulated in that. We need to build on that, take the leverage of that the resolution which all the member states have accepted and agreed on. And there are a lot of evidences of the AI which I have seen in the presentations also, which I have seen the talks also from the NGOs and from the different sources. But I think the data remains the key for any to improve the program, to improve the to share the evidences with the program managers, implementers who are the key for implementing. We are here to support all NGOs, all stakeholders, academias, including WHO. We are here to support. But end of the day, it has to be given to the governance, to the one leadership, and that is the Ministry of Health. So it is to be led by the Ministry of Health. All the evidences has to be collated and presented to the Ministry of Health in terms of it is accepted. Same happened with the hypertension. I again go back to there because in 2019 there was an app which was called Simple App, but we cannot sustain the Simple App for hypertension project for one as working in a silo. It has to be adopted by the Ministry of Health. So now the good practices of Simple App we have given to the Ministry of Health to be adopted in the National NCD portal. And now there is a talk to scale up National NCD portal to include mental health disease, illness and diseases also into it. How it will be done? It needs to expert consultation. It may be depression, anxiety, but I don't know. But there is a discussion in Ministry of Health, and we are discussing that how to scale up the National NCD portal and bring the mental health diseases, illness into that. So my the only suggestion and my only the learning from this is that we have lot of data now, but still the lot of data needs to be brought together from these are the one of the forums where we can discuss and talk on bringing the data together. Dr. Nand mentioned about the difference between mental health and the mental illness and the data gap from mental health and mental illness. So whether our program managers are aware about all this, whether we are presenting to our program managers. Hope this AI summit can be one of the forum where we can present to the program managers about all these the gaps and challenges and what are the good practices which has already been done. So I will stop here and look forward to the discussion more. Thank you very much.
Thank you, Dr. Abhishek. Indeed, you raise important points for us to discuss, and this is a great segue for our next part of the session. May I please invite all the panelists on the stage? So we've looked at that already in today's lightning talks. There's a range of ways in which AI is already being used at a reasonable scale in the country, and there's lots to already learn from existing experience in terms of how AI and mental health intersect in our today's world. Let's now talk about deep dive a little bit into a few thematic rounds to discuss that while we're seeing this already being done, what kind of evidence really exists and for what it exists, and what kind of things we still need to figure out for ourselves. And so this brings me to the first thematic round, looking at evidence and research that exists for mental health. I'd like to ask Dr. Nand Kumar, maybe starting with you, if you could highlight for us a little bit in terms of how ready are we, or where is the evidence, both in terms of mental health and mental illnesses, as you brought out earlier. Where do you see the research is strongly backing application of AI?
Thank you so much. As I mentioned, the evidence base is strong, no doubt about that. Like we have a good number of studies that supports that AI is certainly useful for mental health and mental illness to treat, to support, and to develop intervention also. But if we look at some data like what Dr. Mahan has mentioned, AI psychosis, and it is frequently now reported, like somebody died by suicide, by engaging into too much into the AI. Then the most of the AI what we are seeing are not explainable AI. You cannot ask the question to the AI to explain the things because it's mostly the data. What is available, the database is there. For mental health, it's more important in terms of just awareness, and for that, I think we need to work more with authentic database and authentic information. Like in Instagram only, there are 1 lakh pages of mental health support. So we have to be very, very responsible. We have to be very, very authentic in handling the mental health issues, mental health problem, other things. Lot of framework are being developed internationally, like some sort of framework that focuses on multiple component. Like mental health is not just another illness. Like it's not only in the brain. Like we cannot use neuroimaging and we develop something on that because it's so dynamic. Mental health means the person, the environment, the other external factors. So one factor changes, everything changes. And unlike physical illness, if we build on something, like say for example, to diagnose the tumor of breast cancer, it is replicable. But in mental health, not replicable because we are having the chatbot therapy in the room, closed room. But once we go out of that room, the environment changes and therapy may not work accordingly. So I think till date, whatever data we have, there has to be some sort of robust supervision, and it can assist till date. The AI can assist to have a good mental health setup, good intervention, and diagnosis also. But I think still some supervision is needed. It cannot be left alone. Okay, take AI can do that therapy and all that. So I think what Madam has mentioned, to stop and then the move. No, enough for AI. Now it can shift to the human. I think still we need to do that till we move further and make further advances.
Thank you so much for sharing that. Dr. Prabhat, drawing on what Nand Kumar sir has also mentioned, what do you see is the strength of evidence really available in low resource settings or in countries like India? Your thoughts?
Thank you. Before my anxiety takes over, so let me thank Koita Centre for Digital Health. I was supposed to tell before that the presentation, I forgot. So that's where AI comes a lot. It helps you decrease anxiety. Just speaking so many people. Okay, coming back to the question that you asked me, I think we need to distinguish two things very clearly. Are you talking about mental health or are you talking about psychiatric disorder? The two are different. Mental health is a big spectrum, and I mean, as you mentioned, many of us actually navigated some mental health issue in our own life. I was telling Anand and colleagues that we started a program, Mental Health for the Doctors. And this is just because, you must have heard many events happened recently with doctor suicide. I think sir mentioned about those things. And when we started the program about digitally, we realized that how to talk about those issues from your side before you're telling to patients. Patients are sort of, other side of the table. It's easier to talk to them, but difficult to talk to peer. So that's where AI actually has a great role. We didn't use any AI in all this condition. But coming to the evidence for the AI, I think if you look at the AI and how AI works, I know many of you must be knowing here. So AI is basically, it uses two basic principles: machine learning and large language model. These are two key facts. And what machine learning means, you show him one variety of mango, he should able to identify all varieties of mango. You do not show him all varieties of mango to identify. This capacity is so good, he should identify it. But that's difficult in the challenging mental illness. One delusion of infidelity, which is suspecting wife, is very difficult delusion of infidelity with, and to make it generalizable, it's a tough one. So that's where many studies in AIs, which has been from the many countries, what they do in the health sector, you train from the data of 80%, existing data is already available in the EHR, run it in next 20% and tell my AI is working very good. This is normally AI tested. But ideally setting is that you take a data from the one, teach the machine about one set of illness, take that data and train in another hospital, is he able to predict correctly the data set. And I think I could find one study which I sort of liked it. They did the reason this study is good, because they did in King's College of London. They did a study in the two group of people. One group is a chronic schizophrenia, treated in the hospital for a long time. 594 patients database taken. They have been already on treatment. So they taken their age of onset, symptoms, dose of antipsychotic, response antipsychotic. They developed the algorithm, machine learning in a model. And then that data they applied in early onset psychosis, who came first time to a hospital, not start treatment yet. Can you predict this data to this group, their response rate to the medication, their psychopathology, and how it shows actually pretty good result. I mean, stage of illness, and they found almost 60% of concurrence, which I thought is very good for a diagnosable psychiatric illness where things are heterogeneous. I think this model, I thought, is one of the best model to compare in the non-existence of the many models available at this point of time for the AI group, because like many other medication, placebo and all things are not going to work in this model. So where this, and in this study what they've done, again they reverse the sort of model and they found effective. So I think maybe that is one of the best model I found in the mental health area. One other model, if again time allows, I'll tell. As a clinician, you always have a dilemma when somebody comes to for a depression, which medicine I should give. I mean, I have always a dilemma. I'll ask me honestly, should I give escitalopram, sertraline, or these are medication names, venlafaxine, or a couple of medicines are there. So one study they found out, putting all the data in China, I think 50,000 people hospital data, and they could safely predict who among they taken 4 antidepressant, who will go to respond in the out of the 4. I think these two are the large scale studies that have been published in the peer reviewed journal. So that is what I thought is important. I think that is from my side.
Thank you, Dr. Prabhat. That was really helpful to know that so what we are hearing is that there is evidence is emerging, and so we're best placed to put AI in an assistance mode as far as clinical care in terms of diagnosing, predicting diagnosis or treatment, or predicting outcomes of treatment and personalized care is concerned. Thank you very much for that quick summary. Over to you, Dr. Abhishek, for just to talk about evidence that you mentioned earlier, that the Ministry of Health would definitely require a lot of evidence backing for something like this to be adopted. Just give our audience a little bit of glimpse into what really is the level of evidence that you need to say that yes, this would work and we can take it at scale.
Yeah, thank you. So first I will say that what is the learning is that there are some the improvements in terms of the AI for the care for the depression, anxiety and other diseases. So there are some evidences in which we all know about that, and it has been worked by the many of the stakeholders, partners. So this all needs to be collated, and it needs to be collated in the way that it can be presented well. So what we do, we improve, we learn, we improve, and when we present it case, that it has to be implementable. Second is that the evidences in terms of the equity also. If you see the urban, rural, urban, the evidences has to be there in the terms of care and reach also, gender also, age related, and then there are socio-economic status also. So these evidences has to be generated, because with NCDs, if you take the overall the ambit of NCDs, it's growing. Not only the mental health, it's all the diseases of the NCDs are growing. See the hypertension burden, cancer burden. So it's growing, and we are lagging behind, and the NCDs are growing, because there is a shift, epidemiological shift from the non-communicable to non-communicable disease, and that we have to factor it. So we have to move fast and generate evidence, awareness also. But any implementation has to be in the phased manner. We cannot replicate one model to replicate in the pan India. It has to be phased manner. Learn from the implementation in a phased manner, and then improve and then scale. And any scalable scale has to be a sustainable model. But again, one thing I would like to emphasize on the in terms of financing, which I don't know how to present to the government, because I don't have evidence on the financing. But for any care, any primary health services, primary health care, community level care, or the mass scale care, there has to be sustainable financing. So how to what the I think many of our partners are working on the in terms of mental health care and the AI. So what will be the presentation for what will be the data for the financing? Because finance will be the key for the any sustainable model or any tool. And I think the AI will be one of the best tool for the mental health, because the stigma it takes care of the stigma. Because I have heard from the experts also, that because patients don't come out. If I have anxiety now, I will not come out now. So that, but I can come out through the machine tools. I can come out through AI, because nobody knows. So AI will be the one of the best tools for the patients coming out to share their issues and the problems in terms of the mental health, or maybe mental illness. I don't know. But again, these all data and evidence has to be collated, and I don't have any one point to share that how it will be done, but it has to be collated, and it has to be bring in a way that it can be implementable, scalable, and sustainable, and very cost effective. Thank you.
Thank you so much, Dr. Abhishek. I'd like to next ask Dr. Anand to weigh in that, having heard this evidence and research synthesis from the morning, what do you think are some of the clearer boundaries or considerations around ethical and clinical realities that are on table at the moment with respect to AI?
So, thanks, Rachana. So, few things. One, of course, from the ethics perspective, some thoughts are, of course, how much do we know in terms of what is being done at the front end? So consent considerations would be an important component, right? And for that, we also need to understand how and in which way is AI being leveraged and used, right? So if AI tools are used, then, what is it being used for? What kind of your own data is being leveraged? If it is an application, say in the mental health space, then is that AI based on contextual information which captures the lived realities of people like you, right? Because of course, if the tool is leveraging a Danish data set, it's hardly going to be useful. And I know a lot of efforts are being put into that by colleagues at companies which are represented in the panel, Wysa, Soulup, for example, in trying to develop that. But that's extremely important, because from a user perspective, unless I'm confident about the expertise which is being deployed, right? Why do I go to a clinician? I go with a certain trust threshold that this clinician is competent enough to be able to provide care to me, right? And if the clinician or the hospital or the facility is deploying AI as an accessory tool itself, then that level of confidence has to translate into that tool itself, right? Because just like we have quality threshold for lab parameters, which is a clinical accessory, right? The clinician will write up a set of laboratory tests. The clinician is also using then maybe an AI tool. But do we have that confidence, right? So that veracity and fidelity part becomes important. The second aspect, of course, is privacy and confidentiality. And that, I think in mental health, it's even more important because people are very concerned about what about them might be known to the external world. And if there is a loss of trust in that paradigm, then you're going to probably lose that patient. And that's an extremely important issue for the mental health field, because we've already talked about the fact that many people don't want to be screened. And if they have come to you, then retaining them and ensuring that they can keep accessing care becomes important. So if that is not happening, then that's going to be a challenge. Doing it in a fair and equitable manner, because a lot of tool availability and deployment still, I would say, is among the more privileged in our context, right? It's very much urban. It's largely with people who have access to technology, have the resources to be able to use the technology. But would it, for example, represent the needs of someone who lives in rural India? Does it represent the needs for someone living in Meghalaya, which is 85% tribal? Does it represent the needs for someone who is a non-binary person, a queer person, right, or a person with disability? And how do we ensure that the tools are able to provide care which is accessible but also affirmative in nature? And the challenge is that routine care as it is not affirmative and accessible, right? So is AI going to further accentuate the existing inequities and the capacity gaps or something? And that brings me to the clinical question, right? So clinicians or facilities which are going to deploy AI will really need to do a very quick learning curve in this. And we all know from our COVID experience that initially there is a lot of sometimes investment in infrastructure. For example, you had this whole slew of oxygen plants which were suddenly bought, and now if you go to most hospitals, they are in some corner and probably not being used. So it can be heavy infrastructure expenses initially, but are we going to then ensure that these are retained? Abhishek was talking about the fact that NCD portal usage, for example, in some of the districts that we have worked with, initially they planned for only 50 GB usage of data. And they realized 50 GB was something that they were getting within a week. And after that, they just did not have space for the patient data which was coming in. So unless you really are anticipating the kind of data space and the cost attached to it, I mean, for those of us who work in the civil society space, even we struggle. We get project funding and we might pay AWS or Google for their server space. But then, that is a budget item for us. But then sustainability is a big question, right? Because the month you don't pay the bill, they're going to just probably delete your data in no time. Then what happens, right? Because it goes back to our accountability, patient data, the resources which have been put in. So in planning for that, for the clinician, for the facility, for the health system, they will need to really think it through. How are you going to make it sustainable? Is this infra still available? Does it need to be indigenous? Because there are a lot of concerns about data being exported, what kind of data. And then you have the DPDP Act now and the rules coming in. That's another layer where I think there is a lot of confusion. Most people don't understand how to implement it. So I think it's in that paradigm that we need to figure out a way to hence use AI in a way that it is patient-centric. It helps us make our pathways more efficient, but do it from an ethical perspective.
Thank you so much. So this basically says there's a huge learning curve for us as well as we learn to use AI for us as systems, as individuals. Now, this brings me to the next panelists who are representing large-scale interventions or building up larger-scale interventions using AI with people. Over to you to delve on the conversation that we've heard so far in terms of evidence, ethical, clinical realities, and we've referred to some of the key challenges on consenting, inherent biases in the models, etc. Over to you to just share your perspectives, probably in a few minutes, to how are you overcoming this in a very practical sense, and then we are open to audience interactions.
So I think as humans, we are inherently biased. And that shows in our own clinical practices. It has shown up in my room. It has shown up in many of the other ways in which clinicians practice. And because we are the ones working for AI, it is very, very, it'll be very utopian to think there'll be no bias ever. There will be bias. We have to accept. First, we begin from this space that there will be some bias, inherent bias. And I think once we accept and acknowledge it, gives us the room to then give us the confidence to help the bias surface. So our constant monitoring of the models that we have. So even if it's So the best models, it's the best models that are existing out there. They will have bias, but I think it will surface one at the first level is the level of interaction. Who is using it? Who are we building it for? Are those needs well represented? Are we bringing everybody has kind of brought that up. If we are building for a certain population and we are trying to implement it with a completely different kind of population in a very different context. In India, we have so many lived realities just within the country or within a specific state or within a specific city itself. What are we trying to do? How generalized are we trying to make it? From my experience so far and the way we have worked at Wysa, we've realized that there is only as much as we can generalize. Once we start working with specific communities or specific use cases, it has to then cater to that specific use case. We have to involve individuals, people with experiences, whether it's a clinician. Even if I'm building a summarizing tool for a clinician, is it going to be really relevant for them, or do I think what I am building is the best for them? Like we often even say in clinical practice, right? As a therapist, I cannot decide this therapy is going to work best for this particular patient, even if I know CBT is the gold standard for anxiety or depression. I might have a client whose context is really different. They're coming in with grief initially, where I cannot just ask them to reappraise the situation or the thought, because they're coming in with grief. So if I bring in something which is gold standard and considered specific for a specific diagnosis, even there I'm bringing in my own bias of knowing more and not kind of acknowledging what the other person is bringing in or struggling with. So I think how we are doing it at Wysa is that we are constantly, there's a team of clinicians and people from the AI who are doing aptness analysis of all the conversations that are happening. We are also not just looking at what's engaging people, we are looking at what's not engaging people, which are the conversations that people are dropping off, which are the tools which are not being used, which are the places where we are seeing absolutely poor responses where conversations are ended midway. And those are cues where we go deeper and dig deeper and say what is happening. Are we, for example, grief is something which we noticed initially because when we began with Wysa, we began it as a CBT tool. CBT, primarily CBT driven algorithms and conversations. And we realized CBT doesn't work for everyone. It is not going to help someone who's saying, I just lost my pet. And I can't ask them, okay, let's look at this thought differently. It's not a thought, it's a reality that they are actually experiencing at that point in time. And we realized that we had to then bring in um, more things that would make a certain person experiencing this context feel represented and heard. And I think it's a constant process. Once AI is built, I always say it cannot be shelved. Sustainability is the real problem, because we have to constantly engage with monitoring our models, constantly do aptness analysis, constantly assess what biases are surfacing, and make an intentional effort if we are going to make certain claims. For example, my app uh, treats anxiety, or my app is great with screening and detection, is 95 or 98% for this particular category. If I want to shift the category, then an intentional effort in a phased way will have to be made to first pilot, do a better version, and then kind of take it to scale from there. And also addressing to what Dr. So you were saying with regards to the funding part, what we've realized, how we have been able to get little bit of funding support that we have from the government is by doing pilots for specific cohorts and states. And once we see this use case is working really well, we are doing very good with just basic detection and basic acknowledgement and addressing of problems that could be present in other communities. Then is it when we get permission to take it to another state. But then we also have to kind of somewhere repeat our co-design efforts with cohorts from those communities to ensure that we are doing X well, but we are also seeing that there is Y in their needs. Now, how do we bring in that Y? So, yeah.
I mean, I think most of what I would have said is kind of covered. But I think the one or two things that we've wanted to do, because a lot of this is now coming to the fore that these biases will exist, is and because we started with a very different model where we have a lot of labeled data, we're working with an established, like a set of verified people who come in with a specific lived experience. is start having them chat with AI systems, and then understanding how they express, what they find helpful, what they find brings in bias, and kind of, you know, studying and analyzing where that's happening. So where is bias existing? I won't say we've solved it. We are just trying to identify. So that's the stage where we are at. And to put something controversial out there, I mean, bias is just everywhere. Even in my human interaction, it is there. So, I mean, the other thing that we're trying to do parallelly is, to what degree do we, even because, we want to be able to talk to clinicians. Of course, we want to be able to connect people to other people who have lived experience. And we want homogeneity there, where I'm saying, okay, I'm somebody who's living with cancer, who's experienced also maybe a failed marriage. And I want to talk to somebody else who's also coming from a traumatic marriage and has cancer. So I want to kind of say, connect on this homogeneity. So there is bias, there is trauma bonding. So to what degree do we remove bias? To what degree do we challenge that individual with a different perspective? So those lines are getting blurred for us. We are trying to figure this out, but we haven't.
Thank you so much for that, sharing that. Now the floor is open. I'd like to invite questions from the audience. Yes, Ashish, over to you.
It's about maintaining the homogeneity. I'm just, posing a situation. Let's say I'm suffering from cancer and I'm also divorcee. I want to know. But, and let's say if I'm looking for people who are also sort of experiencing the same situation, but in the platform there are not. Like, I mean, how many people are going to be suffering from cancer and also divorcing? So under which bracket will I fall that I access the app? To repeat, like, will I be meeting or interacting with people who are suffering from cancer exclusively, just so I could, share that, communicate, and, my thinking? Or will I be looking at interacting with people who are not suffering from that?
You want to answer it right away, or should we take a few questions?
I'm good with anything. I can answer it quickly if you want.
All right. Yeah.
So the ideal case scenario would be that everybody's on the app. So you will find at least one person who has the same background as you. But we are far from there. We are 1,000 people. So if you slice and start slicing and dicing the data, if I'm looking at multiple points of commonality, they start reducing. That is ideal. Otherwise, what we do currently with our limited peer network is say, what is the biggest thing that you're trying to solve? If your biggest thing that you're trying to solve is coping well with cancer, then let's start connecting there. So you start from one point of commonality.
Thank you. Yeah, so now we'll take a few questions, and then if we have time, we'll come back to your question, but we'll give others an opportunity to ask questions. Yes, over to you.
Forgive me, I'm not a student of the sciences, so my question might be a little out of scope. But what about, say, if you're facing a mental health issue that is not caused by your individual circumstances? I know many peers of mine who suffer from a lot of depressive episodes precisely because, say, they are political science students. We deal with a lot of news on the daily, and seeing a lot of, like, say, climate change issues or pollution issues, etc., etc. We often frequently, bond over the fact that it seems extremely depressive and, kind of doomed almost. And now, how do I, as a user of these platforms, of these cases, what is stopping me from then just going to an AI and saying, listen, I feel like this, etc., etc., and it telling me like whatever I want to hear, etc. What is how do you then resolve this issue? Because in my mind, at least, the solution is not to tell the user that yes, everything will be fine, right? And my second question is, one of the speakers, ma'am, I believe the youth said community is very important. I fully agree. We see this constantly in sociological studies. Community is the most important thing for a human. My issue is also that online, a lot of communities increasingly cater toward many and much more radical spaces online nowadays. In the West especially, a lot of young men have become increasingly radicalized towards misogyny and white supremacy online. And it's because, again, it provides community spaces for people to interact with each other. How would you then reach out to these people and de-radicalize them out of those spaces but you're taking away their community from them, right? And just as a final comment, I had other questions about surveillance and inclusivity, but I think you all have mentioned it and it has been answered very well. So thank you so much.
Thank you. Any more questions? We'll take a couple more before we hand it over. Yes, ma'am. Yes. Yes, you can go, ma'am, and then sir, over to you.
Check the person is who's suffering the mental health. So it followed the person is already suffering from mental health and it he or she do the chatbot for some decision making support. So like how relevant that chatbot is, because the data set on which the chatbot or AI tool is trained is sometimes for depression, anxiety, dysphoria, mental epiphany. But if the patient is going to a psychiatrist or a psychologist, he consulting what is the facial expressions, the body language, everything. But like how reliable the chatbot for that situation is? Because if someone suppressed, like he or she start using the chatbot because of the like there is some hesitation also. Because I'm working in the community like from the last 2.5 years, so there is a barrier. But if now if the data set is like generated to train the model, and if we get the consent from the patient, like if we are recording your conversation to train the AI model, so that also creates a barrier for the user. So like how to handle that situation?
Thank you. Sir, your question.
My question is like you did the like AI, Jibola said that it's not a complete package for the mental health situation. Or as such said, there are multiple attributing factor for the mental health. Somebody is facing unemployment, somebody facing child issues, somebody, and there are n number of issues. And AI is not for the preventive aspect; it's more related with the management aspect. However, like there are multiple program planning from the government side as well, like National Mental Health Program. So we may have go to what approaches, interventions are being implemented through that program. So what are the gaps where AI at this point of time can plug in and can help to better implement the national program, because their audience and the reach is very, very at the scale, which we all intend for that benefit should be going to the larger audience. Secondly, when somebody is feeling, they just pop up maybe on Instagram, maybe on the Facebook or other social media platform. So these tech companies, how they are responsible that if there is any such pattern emerging from individual or from certain communities, how they are responsible to flag those issues to somewhere at the central depository. So ultimately, we want that if I come across that person is suffering from some mental health issue, then what is my responsibility to address that hard problem? Same way, these big companies, how they are responsible if somebody I'm facing that issue and I'm flagging that issue on that certain platform. So where they will be, directing me for the care from the mental health perspective. Are we taking on that platform as well?
I think that's an excellent question, and we should start from that question. Let's hear about that first, and then we come to the other question.
There were a lot of questions. I may have, given my memory issues, forgotten a few of them, but the gist remains. I'll, like we said, start from your question, sir. So, yeah, I think even when we launched 10 years ago, when there was no GPT, as a clinician, like I said, as a clinician, I was employed by a tech company, and I had that load on my head that if somebody, to that question which I said, the first question the bot asks is, how are you doing today? They said, I'm feeling suicidal, or I'm feeling at risk for something, or I'm bringing in a certain condition, I'm not knowing where to go and seek help. What will we do with that response? Right? So the first thing that I'm glad, and I can say with confidence, a lot of tech companies today who are building for mental health. I cannot comment on general purpose AIs like the GPTs and the Geminis of the world, who have also now become more conscious given all the litigations and cases that have now been brought up, and people are becoming more active and kind of suing these companies also. So just first principles. Yeah. Just very first principles thinking is that there has to be an escalation pathway. For that escalation pathway to work, the detection of these high risk explicit and implicit has to be really good, which is, like I said, is a work in progress. We can begin from certain keywords which can help us identify what these risks could be, what are the things that we need signposting to a human professional, and who are again we building for example, for the app that is just there on Play Store for people to use from anywhere in the world. These signpostings go to the local national helplines where they can be connected with, and these, it's not just, the job doesn't end at putting the helplines there. Companies are responsible to also test and check if these helplines are functional and working. Sometimes numbers change. Sometimes the helplines stop functioning, they're redundant. Sometimes the helpfulness is not great. So, for example, at Wysa, we do it every 3 months. Every 3 months, somebody from the team will run a check for all the helplines that we have put in for across the globe. And they have to see how functional and how effective they are, and then look at asking for more such scenarios. For partnerships, for example, we are implemented with the Ministry of Health and Technology Singapore, the Singaporean population, or for the NHS, for the patients that are coming in NHS. Anytime the risk is detected or people on certain, say, 𝐏𝐚𝐬𝐿 GAD-7 depression anxiety screenings show a score which is showing risk, they're again signposted towards clinicians. So that is what what mental health and tech companies are doing specifically for mental.
So we might just have a few minutes left in today's.
So the question regarding that homogeneity. No, it's a very difficult, in fact. Suppose if you are having the cancer, suppose on some illness, and you are trying to find the person with same illness. So it's very dynamic. It can go either way. Either it can make you more depressed, or it can, if the person is recovering, that can help you, in fact, to come out of that. So that always does not work. So there has to be some sort of dynamic, some sort of heterogeneous group also. Like what we do in mental health setup, we don't admit all the patients of depression in one ward, because all are depressed. So all will share with each other, okay, life is so worthless, what is point in living, let us die. So same thing happens here also in this all chatbot communication. So we have to be careful in that. So the important thing here is you have to be aware what is being done to you, either by in-person consultation or the AI. So the same thing happened that also. It happens mostly once you talk to the chatbot. It starts with very good language. Oh, I can understand you. It's not uncommon. So if you say it's not uncommon, that may precipitate further. Okay, it is not uncommon, so I can do it. So if I'm having the cannabis, and if I'm being told with the chatbot, it's not uncommon, people take it, but how it is affecting you. So it normalizes that also. So how it works on you, that depends on you also and your mental state. So this is the difference between the AI and in-person consultation. Like in-person consultation, lot of things can be sorted out. Because in human mind, algorithm perhaps it cannot be replicated like human mind. Because one stimulus can give rise to at least 10 kind of output. Maybe 20,000. Like for example, if you are slapped and your sister is slapped by the parents, your brain react differently, your sister brain will react differently. But AI will not do that. So the processing is very, very different of human brain. So we're trying to be close to that, but still, as I try to convey, it need to be supervised. Still, we can make best use of the AI, but perhaps we cannot be totally dependent on that. One of the question we had asked, there is no issue. Still, person can be depressed. So depression does not mean only psychological. A lot of biological things also happen. Say, for example, winter depression. It's nothing psychological. It happens. People at high altitude, they may develop depression. And if you are on some medication or there is some chemical alteration without any external reason, you may develop depression. So that is one of the example. It's not that you are hearing something like everybody hears that news, the bad news, but everybody doesn't develop depression. So the brain reacts differently, in fact. And the community is important for the reason, like it's not that pulling you. It's important so that your sensory activation is there. If you are shut down in one room, your sensory, you are deprived in terms of sensory stimulation. And then perhaps your mental health depends a lot on sensory stimulation. Say, for example, if you are here, your thought process is different. If you go to cremation, your thought is different. So environment is so important. So community plays a role of environment, in fact. And then it is important. It's not like, pulling and pushing. Of course, it happens in real life. So ultimately, your health depends on how you are able to understand your thought, your feeling, your action. The health depends on that. And once you're able to understand health, you can understand illness better.
Thank you so much. We really are short of time. Yes, unless you have a please pressing point, then.
No, I will one line will tell. I think the bottom line is that we are far, far away from all this stuff. Okay, looking at this, speaking about the whole country as a whole, but I think what you can do for your colleagues and friends, if you feel somebody has facing difficult times and thing, Government of India by Prime Minister of India has started TeleManas program 14416. It's a completely free program by Government of India that runs it. Maybe connect to one of those, run 24/7, and advise the person that can you connect to them. They are all trained counselor. They at least guide you. I mean, I'm not telling them, but they're now they're linking to a psychiatrist, absolutely by the government resources. It was free. But I think time at this point of time, if you look at AI, only screening tool beyond and nothing else. Still, it's a long way to go. Thank you.
Thank you. That's helpful. Last word, Dr. Abhishek, and then Smriti, and then we'll close.
Just one point about the National Mental Health Action Plan. I think that is the broader picture, and all the learnings has to become there. And Telemanas is the one of the tool when we need to see that how to integrate the AI into the Telemanas, because that is already has a scale, and that is being implemented and is going to be implemented in a large scale in a different ways also. So, but we need to see that all these AI tools has to be come into the national structure of the Telemanas and other national mental health action plan. So thank you. And about the standard, I think the one of the things is that in the NCDs, because we are going for a mass, so standard treatment protocol or standard treatment care is very important for the primary health care and the community level, and that is the experts has to come at the evidence-based standard treatment care for the primary health care, at least for Ayushman Arogya Mandir and primary health care at the primary level. Thank you very much.
I'll answer your question, and maybe it'll address your question also, that to just use the kind of chatbots that exist in the general world, which is like the ChatGPT or LMI, the other Geminis, you may have to go and frame the right kind of question and get your answers right. They're not built for mental health. I think something we didn't touch upon but is very relevant in AI and mental health world is digital literacy skill. What tools do we have to use for mental health? If I'm feeling upset, if I'm feeling anxious, if I'm feeling a certain kind of anxiety, do I just go to a chat GPT and ask something? It will give you, it is basically data in and data out that's happening over there. It's not built for addressing mental health support. So it will give all sorts of responses which may also cause harm or trigger harm. So the best thing is to know, to read more before what it can specifically help with. It is all of our responsibility also, both on our side to kind of inform upfront transparently what these AI is for. But if it's not, then that initial effort may be needed to kind of figure out where I'm asking for help and what help can this provide. Like sir said, one can actually dial a helpline or a emotional support crisis center to get more support if you're feeling all kind of difficult feelings, or take support from a chatbot that's built for mental health. That'll not cause any harm, even if it doesn't really help to an extent you're expecting to help. And a lot of chatbots are not primed to offer very specific contextual decision support, except things like the GPT. But they can really personalize things to an extent. But again, we have to remember they're not built for mental health. There are no clinicians sitting in their team who are guiding them as to what are safe responses and what are unsafe responses. So I think a lot of tools, and there are there in the preventive space. Wysa is a preventative mental health tool, which helps with individuals build the skills to be able to work through the problems that they are facing. So it will not say, okay, do this, do this, do this. As a therapist, I also don't tell my client that. So it will give you the skill to be able to do a pros and cons analysis on your.
Okay, I'll quickly.
Like, can you please respond to this, because the covered communities now we are being asked by the organizers outside the gate to also close as the next session is here. So I'd really love to, this conversation clearly is not ended, and there are many aspects that still require a lot of deep deliberation, especially my mistake you can identify sitting over there when I stutter, and you can tell me, I can identify, my boss can identify, but if an AI makes a mistake while responding to your chatbot, you will not know, I will not know, my boss will probably know even later. So I think there, the accountability rests with how we would identify information that is actually providing erroneous responses. And because of that, today the support is towards looking at AI from a more assistive and be your own light before you make a decision about how you would use AI. So on that note, I would really love to thank all the wonderful panelists for your lightning talks, wonderful insights over the panel discussion, your generosity in responding to audience questions, and for your interest and presence in the room today. Let's continue the conversation later outside. Thank you.
Meeting. Was a pleasure. I'm teaching 𝐏𝐚𝐧𝐞𝐥 𝐃𝐢𝐬𝐜 was easy.